Welcome to the BJ360 Podcast. This is the inaugural September 2020 episode. I'm Sarah Gill, Orthopaedic Trauma Consultant at the Queen Elizabeth University Hospital in Glasgow, and I'm delighted to be hosting this podcast. Our plan is to have a monthly podcast alternating between a journal club discussion of the papers in the recent 360 issue and a roundtable discussions on topics that affect our day-to-day clinical practice that we really hope will be of interest to our listenership. Whether you're joining us on your daily commute or your weekend jog or just waiting for that quick spinal unblock to cook, we're very grateful that you've taken time to listen. It only seems polite and frankly sensible to commence the podcast by asking two of the BJ360 editorial team to join me today, and that is Mr. Brett Roccos and Professor Ben Ollivere. Brett is currently the Senior Neuro-Orthopaedic Spine Fellow in Toronto Western Hospital. He previously completed a spine and trauma fellowship also in Toronto and finished his training in Bristol in 2019. He's involved in the Exile Medics group, providing medical support to many varied extreme sports races. And I'm told that's in fact where he first met our second panel member who barely needs an introduction. Professor Ben Ollivere is a professor in trauma and orthopedics at Queen's Medical Centre in Nottingham. He's the editor-in-chief of 360 and a full-time trauma surgeon with a specific interest in trauma frames in non-unions. And as well as having contributed a huge amount to large multi-center studies over the last few years, he has certainly contributed a lot to the emerging rib fracture fixation practice in the UK. In the first half of the September episode, we're going to ask Mr. Brett Roccos for his 3 papers of highlight from the August edition of the BJJ360, and then we're going to discuss in detail the paper he selected, which addresses the question of complete traumatic spinal cord injury. I'd like to start off today's podcast just by drawing attention to the feature from the August 2020 BJJ360. And this really looked at the somewhat unpopular topic, I'm sure, of litigation and claims. And the way this has been looked at by John Machin, who's the clinical lead for litigation as part of the GIRF program, is that program's contribution to how claims have changed over the years in relation to trauma and orthopedics. And the good news is that there's been a drop in the number of claims and costs associated with those claims over the last 4 years in TNO, which is not what we've seen in other surgical disciplines. And I think that's very encouraging. But one of the key things that I actually took away from this piece is that only 1/3 of claims relate to a previously lodged complaint or critical incident. And that really made me think about how we use our M&Ms and how we collect M&M data. I think it's a very sensitive subject, obviously. Claims made against clinicians are made against departments. But the key message here was that unless that information is being shared as part of M&M and lessons are being learned, then we might be really robbing ourselves of what is really useful information going forward and improving our practice in relation to patients. So this was a very positive piece. It really looks like GIRF has put us ahead of the curve in orthopedics, and it articulates what we already know, which is that learning from claims and incidents is really important in improving patient care, and it really relies upon robust local systematic practices, and that managerial engagement in that dialogue is essential. So it really made me think about going back to the department and looking at how we manage our M&M data.
I think that's right, Sarah. I think it's one of those kind of dark secrets, isn't it, that people try and hide in the corner, the number of claims that are going on and that sort of stuff. And it is really difficult when one comes in. You know, personally, I've had a couple over the years, and you get protected from it as a trainee, and then you start as a consultant and you find suddenly there's all these complaints.
Mm-hmm.
And you sort of try and deal with them, and you know, often they're unfair and so on. But actually the truth is that the complaint leads to the claim, and if you recognize the complaint, it's not necessarily accepting guilt, but there's patterns of behavior that result in complaints, and actually minimizing those seems a sensible thing to do. And I think that's a really, you know, good message from the paper. And I agree with you. You know, complaints are very rarely discussed at M&M. You know, who wants to go through their dirty laundry, so to speak?
Yeah, I mean, in spines, we're certainly acutely aware of the risks that we're undertaking, and complaints are a big part of that. And if you look at the business literature, we know that for every 1 complaint we receive, there's 8 to 10 that are considered by somebody that aren't submitted. So people are aware that these mistakes and problems are occurring. They're just not getting around to submitting complaints. The other thing is to come back to Ben's point there about, you know, as a trainee, you know, we don't have a concept of how complaints and claims and so on move through the system, and how to not just prevent them, but how to address them as an inevitable part of practice, and incorporating that into the M&M process where invariably the trainees are involved. I think it's key, and will be a key part of the preparing for consultant practice shift we're seeing in the syllabus for trainees.
Yeah, I think they're really interesting highlights, particularly as you say, the bridge between sort of trainee and then moving into consultantship. And I think it very much does feel like the dirty laundry. And that's why I think maybe management facilitation of those discussions, in a very, it's very easy to say non-judgmental way, etc. But I think it's actually vital rather for the integrity of the process. And I think it's something that, certainly I think we could, all look at probably most departments is how we deal with that.
I think that's right.
Brett, if we come to you next, your papers to highlight.
Yeah, absolutely. So I'm always impressed when we go through the papers that we choose, those, as you say, that have a direct impact on practice. And what always catches my eye are the negative results, because I think too often papers are published when they've got impressive positive results. So the three I've chosen are two spine, predictably, and one actually from the oncology literature. And the first I've looked at is a study out of Taipei in Taiwan that compares orotracheal intubation with nasotracheal intubation when you're doing anterior cervical decompressions and fusions. We know that things like hoarse voice and dysphagia and things following surgery are really common. And what this paper's done is compared two groups with 55 in each patient with orotracheal intubation and nasotracheal intubation, a really simple methodology. Everything else all being equal, cuff pressures inflated to the same pressure and so on. But what they've shown is that the nasotracheal tubes actually gives you a lower impact of lower incidence of dysphagia and hoarseness of voice. And from my own experience, I know that this is something that patients are alarmed with the moment they wake up. And so anything that reduces the incidence of that complication, I think, is really useful. It's not something we typically consider, but it's something we can direct our anesthetic colleagues towards and say, hey, have you thought of this? It's a really practical tip, and there's some decent evidence to support it. And it's pretty robust paper, so I'd certainly recommend anybody who's involved in that sort of practice looking at it. The second paper that drew my attention actually it's quite a short paper, and again, very practical. It's again spine, and it talks about how if we start cases later in the day, how those cases cost more money, take longer, and have a higher rate of complication. And this is a retrospective analysis, and they looked at over 3,500 patients elective patients who had ACD and posterior cervical decompression and fusion over 8 years, and they divided them into those cases that started before or after 2 p.m. And what they found was that when they conducted sub-analysis, the patients undergoing the surgery in the later group were more likely to be discharged to somewhere other than their own home, were more likely to return to the operating theatre during their initial stay for a complication, wound complication, or hematoma or something like that, and were more likely to return to the emergency department within 3 months following surgery. They've concluded that actually better scheduling is a way to decrease utilization and costs. I suspect that it's slightly more complicated than that, of just saying, before or after lunch. But it starts to really lend evidence to recognize that actually we are human, we do get tired. Starting later in the day, is not always a great idea for these more complicated patients. And maybe it's something, again, we need to draw attention of our theatre scheduling staff and so on towards, just being a bit more cognizant of what cases we're doing when. And lastly, and somewhat perhaps atypically, I've taken something from the oncology literature, and this just appealed to me because I thought it's a great study that's going to influence care. And what this group out of Columbus in the USA have done, have looked at neoadjuvant radiation and improving the negative margin resection in sarcoma in the extremity. And what they've done is they've taken 1,400 patients from the US cancer database, and they've conducted a sub-analysis looking at those who underwent neoadjuvant, adjuvant, and no radiotherapy prior to extremity sarcoma, and actually found that neoadjuvant therapy led to a higher frequency of negative margins, but didn't influence survival at all in this group. They showed that radiation at any point during the treatment reduces local recurrences, which I suppose stands to reason and goes alongside the existing literature. But I thought that, actually this is a group that stood up on their pedestal and said, actually neoadjuvant radiotherapy, yeah, goes with all the others, but actually it doesn't really improve survival compared to normal treatment. Maybe it compromises post-operative wound care. But actually, they've pinned their hat on the wall and said, improves resection, but not the survival. So, perhaps there's something to think about. But as I say, a negative result is still a useful result. And I think it's going to influence the treatment of these patients with extremity sarcoma.
Yeah, fantastic. Yeah, really succinct Summaries are a very complex paper, so thank you. Thanks very much for that, Brett. Right, we're going to move on to the sort of the main course, as it were. So, Brett, you have chosen a spinal paper that talks about essentially complete traumatic spinal cord injuries, and I found this paper really fascinating as someone who has, no spinal practice, but is, obviously involved in patients around the peripheries in terms of the multiply injured patient, etc. So I was really interested by this paper and really interested to get your take on it.
Yeah. So it's, spinal cord injury, across the UK is really centralized in regional centers and so on. But I think it's something that I would certainly expect every orthopedic trainee, and if not consultant involved in trauma care, to be aware of. Going back over the last decade or so, there's been a lot of interest and some really good quality studies looking at traumatic spinal cord injury. And this paper out of Amsterdam really has sought to bring all those together in almost a narrative review type format. And what they've done is looked at the outcomes of traumatic spinal cord injury with a complete Asia A injury in the cervical, the thoracic, and effectively the conus or cauda equina. And they've taken each of those in subsections and looked at how useful early decompression is when tackling each of those. Now, of course, the cervical spine, we all know, is the most vulnerable to a complete spinal cord injury. And that's probably the most well-trodden route, looking back to something fairly landmark like the Stasis trial back in 2012, which almost comprehensively proved that early decompression was the way to go to improve spinal cord recovery by 1 to 2 levels, which can be the difference between being institutionalized and, independent at home if you look at something from a C4 to a 6 and so on. What really caught my eye with this paper was actually that they looked at the evidence for the thoracic cord and the lumbar and conus. And the reason that's interesting is there's a lot less evidence for this. So they looked at the thoracic cord and found that up to 34% of people with cervical spine had total cord injury, but in the thoracic spine that's much less well defined, and that's somewhere between 16 and 73%, so quite a wide range, and it occurs in up to 70% of polytrauma patients have a degree of thoracic spine injury. So it's something we all need to know about. At 1 year, those patients with a thoracic Asia A, 89.3 they've quoted, so now 90% of patients with a thoracic total cord injury will stay with an Asia A. They're not going to improve really a great deal, though they've said the mean recovery is between 0.1 to 4.5 points at 1 year after injury, and that's referring to the Asia score. Again, it's a wide range, and the vast majority will not make an improvement regardless of whether you decompress early or late. When it comes to the conus and the cauda equina, this is where it gets really interesting, because picking those two conflicting diagnoses apart is in practice very difficult to do. And notoriously, the conus medullaris syndrome has an enormously variable presentation, and some centers will treat that as a cauda equina and urgent decompression, and others will leave it to recover on its own. If you have an injury to the conus or the cauda equina, this paper quotes 21% of patients will present with a complete lack of motor and sensory function. That's probably less been my experience. I would say it's probably slightly lower than that, but you can't argue with the numbers here. And they're saying that actually the recovery with a conus or cauda equina injury is better than with a thoracic, with up to between 3 and 5 motor score points improvement compared to 0.1 to 4 in the thoracic cord. This paper, the conclusion really is that surgical decompression of the cord within 24 hours, regardless of where in the cord is injured, is largely difficult to disprove and is to be recommended throughout. And the meta-analysis with regards to cervical cord shows that you get this 2 Asia grade improvement in about 25% of patients who have decompression within a day, 24 hours, rather than 10% in over 24 hours. So the evidence in the cervical cord is pretty clear. And the thoracic cord, as I say, I think the evidence is much less clear. There's a lot less data out there. There's a much more variation in the presentation of a thoracic cord injury. And similarly, in the lumbar spine and cauda equina, again, the data really isn't there to support it. There is some studies looking at comparing your classic cauda equina syndrome that we're familiar with the disc prolapse and perineal numbness and so on, comparing that to an injury and suggesting, well, maybe we should treat them the same. Maybe we should decompress within 8 hours. Maybe that leads to a better outcome. But the data is so vague that it's impossible to really draw a robust conclusion there.
Well, that's really one of the things that I was thinking of that came to my mind when I was reading this, because this is a very comprehensive literature review of sort of trying to bring together the current evidence base. And one of the things I'd written down is looking at the numbers. in the studies, you know, barring the meta-analysis, which looked really at the question of timing of decompression.
Yeah.
The numbers in all of the studies are relatively small, and certainly very small in orthopedic terms. So my first question to you would be, have we got enough data to answer these questions yet? Or is it, this is the best we're going to get because studies of these nature are very difficult?
Yeah. So I think the honest answer is no. If you look at it completely dispassionately, we don't have the numbers to sit here and say there is a right or wrong answer here. You know, the most robust evidence comes from cervical spine. I think there's very little doubt now that early decompression in the C-spine is useful. Outside of that, I think we're looking at a best practice type picture rather than definitive evidence.
Yeah.
Do I think the numbers are ever going to be there? I think over time they might be. A lot of this data comes from North America, where there's a much tighter focus on timing of surgery because of the culture of practice over here. But I think meta-analysis is the only way we're ever going to increase numbers. Mm-hmm. The other problem we're starting to come against, of course, with these studies is the ethics of doing them. There's now increasingly, you know, less and less appetite for doing studies where you're purposefully delaying surgery at all. So these are all observational studies where for some other reason a patient's surgery is delayed. And one of the weaknesses of this that the authors actually mention is that actually in polytrauma patients that are unstable or have other life-threatening injuries, those are the patients that are in the longer than 24-hour surgery group. And those other injuries could be directly related to their cord injury and their lack of recovery following it. Hypotension, a SIRS type response. We know that injures the cord through secondary mechanisms. You know, Failings et al. Showed that, you know, a number of years ago now. So I think it's going to be a very complicated process, and I can see it being incremental rather than a single leap forward. For me, what it's taught me is, well, you know, Brett, it's going to be hard to justify delaying decompression of a cord injury wherever you are in the spine in the absence of a very clear clinical reason not to. Of course, that needs to be balanced with the logistics of where you work in particular. And we can't forget in the UK with our shift in practice that operating at 2 a.m. in a unit that doesn't do this sort of work almost on a routine basis.
Yeah, so exactly, that was, you know, that was something else that you've already touched on another big thing. So if you read this paper in broad brushstrokes, it would say, okay, well, the most common complete traumatic spinal cord injuries is cervical. That's where we've got the most data to say actually these patients do best if A, they're surgically decompressed, and if B, they're surgically decompressed early.
Yeah.
Now, thinking about that, you know, early, i.e. 24 hours of injury. Two questions around that. One is that, would that represent, if we just said, okay, broad brushstrokes, we're going to accept that now as best practice and we're going to institute that, would that represent a significant change in practice in the UK? And B, how doable is that? What would we need to put in place to allow that to happen?
Yeah, so I don't think it would be a radical change in practice, but I do think it would perhaps lead the theatre management profession, if you like, to just rethink their balance of skills and so on, you know, out of hours, because we're in that difficult bridge between neurosurgery and orthopedic surgery where there's a lot of pooling of resource and crossing of nursing staff. So you bring a team familiar with the spine, they may not be familiar with the bilateral the two plating of the distal femur, which is far more likely to need some attention out of hours, or even something simpler like an X-fix. I think it is achievable. I think it is achievable, and I can see a time where it just is what has to be done. I mean, in the same way that I think cord recliners need to be tackled really aggressively, but I do think it will need a shift in practice. Alongside that, speaking, you know, on the soapbox as someone who's recently finished their training, you know, trainees will need to become familiar with identifying this as A, a priority, and B, being able to get the ball rolling with these cases, you know, out of hours. It's not something typically tackled by trainees or more junior nursing staff and so on. So, you know, as the tides shift, you know, we following the consultants need to know what we're doing with this sort of thing.
Yeah, I think certainly, you know, when I you know, was thinking about, you know, the last time that I was considering these questions in a big way was probably, in all honesty, a few years ago, preparing for the FRCS finals, when you're going to be asked to defend your practice regarding certain things. And certainly at that time, it was, I think, accepted that, you know, the non-complete traumatic spinal cord injuries were a much greater clinical priority to the complete.
Yeah.
And the tide has already changed on that, especially with cervical spine stuff.
Yeah, you're right. Yeah, absolutely right. You know, traditionally we were told there's something to lose with those who are incomplete, so we should work quickly, and those who are complete, it's kind of game over. We now know that's not the case. We now know that urgent decompression, you know, prevents that secondary injury that we're seeing with the free radical formation, and some of the drug trials coming in now that are seeking to control that secondary injury rely on that early decompression. So I think those waters have shifted.
That's a really interesting update for me. And other small thing I took away from this was just about who should be doing that initial documentation and assessment. You know, I thought it was really interesting to be acknowledged in this big literature review that actually, you know, the seniority of the person doing that and recording that is really vital, because even there, you know, they were finding in pretty, what were otherwise, you know, as robust a papers as possible, that actually there were significant discrepancies. And therefore, you know, someone experienced needs to be documenting the neurological exam.
Yeah, absolutely. You know, it's something that we do, you know, every day when you're on a neurological or a spine-based practice, and don't think too much about it. But it is something that you're, you know, a non-spinal orientated trainee might do very infrequently, and as you say, particularly around the exam. But aside from that, and we know that in a polytrauma setting, you know, that there's 1,000 things going on at once, and quite often the neurological exam is not cursory, but it has to be done briefly. We've all seen the Asia sheet, which is a very comprehensive documentation of how things are, and you can have another debate about how practical that is. But you know, I think, you know, it needs to be borne in mind, and you just have to do the best you can do. But ultimately, the earlier the decompression is done, I think this is moving in the direction of saying the better the recovery will be for that patient.
Yeah, really fascinating, and a great sort of you know, I think it's a paper with quite a clear message in terms of, as you say, I think the tide sort of, you know, turnings, the sea shifting. I think that's a very sort of thing with this paper, and it kind of lends a lot of credence to some refocus on that as a clinical topic. Brett, thanks for picking such interesting papers and your really interesting insight into that area of surgery. I hope everyone's enjoyed listening to that as much as we've enjoyed taking part in it. And please do join us for the second part of the September podcast, where myself and Ben Ollivere will also contribute our picks from the journal.